Good morning, everyone. Welcome back to the Nima Health Show. Today we have an esteemed nephrologist with us, Dr. Anupam Roy. I'll give you a little brief about him. So, after his MBBS and MD in General Medicine, Dr. Anupam Roy went on to do his DNB in nephrology. He was at Gangaram Hospital for several years, worked at Fortis Vasant Kunj for a couple of years. Thereafter, he was with Columbia Asia. He's practicing in Gurgaon for last 10 years since 2010, and currently he's working as a senior consultant and in the Department of Nephrology and Renal Transplant at the Paras Hospital. It's one of the busiest hospital in Gurgaon. We welcome the senior nephrologist, Dr. Anupam Roy. Doctor.
Madam, good morning. Thank you for the kind words, madam. Good morning, everyone. Today, I am here to talk about urinary tract infections with special reference to those in the elderly. And before I start, I would like to thank Nima Elder Care and Dr. Chetna Jain ma'am for giving me this opportunity to interact with all of you. Without wasting any more time, I'll go directly to the presentation. I hope you can see my presentation. Is it visible, ma'am?
It's coming now. Yes, it is visible.
Yeah. So I will try to focus on urinary tract infections with special reference to those in the elderly population. If we like to define UTIs, it is an infection of the urinary system which can involve anywhere in the urinary tract starting from the kidneys, the ureter, the bladder or the urethra. The infection may be limited just to the bladder where we call it as cystitis, or it may be involving the kidneys where we call it as pyelonephritis. In some patients, the infection initially starts from the bladder and later on ascends up into the kidneys. These are the difficult cases where both the lower tract and upper tract are involved. So, why is it important to discuss this problem of urinary tract infection? So, it is one of the most commonly diagnosed infection in older adults. As the population ages, the burden of urinary tract infection is expected to grow. In fact, there is a data that more than 5% of emergency room visits in the elderly population is related to a urinary tract infection. And since it is also an important indication for antibiotic prescription, it leads to all the problems associated with antibiotics, including development of resistance and other problems with antibiotics. The incidence, if you look at it, is more in the females as compared to the males, and this is across all age groups, from younger to the elderly. In the elderly, there is a data which shows that more than 10% of the women greater than 65 years of age have reported a urinary tract infection at least once in the last 12 months, and this number goes up to more than 30% above the age of 85 years. All these infections will lead to increased morbidity, that is a sense of ill health and impairment of health, which it may be associated with increased hospitalization, and ultimately all these will lead to rise in the cost of care. So it is a very important problem, and in my experience overlooked, many times overlooked problem. So we have to be careful with the presence of urinary tract infections. Why the elderly population? We are targeting the elderly population because this population is more prone to develop urinary tract infections. And the important causes may be there may be age related changes in the immune function. There is a reduction in the innate immunity. There may be comorbidities in this group of population, especially diabetes, etc. There is an increased need for invasive procedures, prosthetic devices, or the need for short term or long term catheterization in this population. In patients with functional impairment or those with cognitive deficits, there may be an increased need for institutional care as well in the elderly population. So that increases the risk factor for this group of population, and that is why we have to be extra careful with the elderly. if we come to the risk factors, then it is important to understand that the strongest and the most consistent risk factor which can predict the occurrence of a urinary tract infection is a previous history of a urinary tract infection. If there is any obstruction to the urinary flow, which will lead to the retention of urine or urinary stasis, it will also be a predisposing factor for urinary tract infection. In males, the most common cause is a prostatic enlargement, which can lead to obstruction and infections, while in females, it may be related to disorders like cystocele or maybe a uterine prolapse, which lead to some degree of obstruction or retention of urinary flow. Similarly, the presence of urinary incontinence also increases the risk for a urinary tract infection. Uh, Change in the vaginal flora as a result of declining estrogen levels is also thought to increase the risk for urinary tract infection in postmenopausal females. Improper handling of an indwelling catheter is a very important risk factor for the development of urinary tract infection. Then coming to medical conditions like stroke, dementia, Parkinson's disease, these disorders may predispose the individual to bladder and bowel incontinence. They may also lead to difficulty in activities of daily living and increase the risk for or the need for catheterization. All these factors put together can contribute towards an increased risk of UTI in the elderly population. The symptoms, coming to the symptoms of a urinary tract infection, the symptoms may be specific to the urinary tract, but there's a problem in the elderly that the symptoms sometimes are very non-specific or maybe vague. In that case, it becomes all the more difficult to approach or to diagnose a patient with a urinary tract infection. Coming to the specific symptoms, it includes fever, maybe more than 38 degrees Celsius, or associated with chills. There may be symptoms of dysuria, that is pain while passing urine. There may be frequency, that is the patient has to go very frequently to pass urine, or there may be urgency, that is once there is an urge to pass urine, patient has to go immediately to void urine, and he cannot hold the urine for a very long time. These symptoms may sometimes be is classified as new or increased in the frequency, urgency, or the pain while micturition, while passing urine that the patient has. Some patients may present with a pain either in the flanks, that is on the side of the abdomen, or in the suprapubic region, that is just at the lower part of the abdomen, belly. Or this pain may again be classified as new onset, or maybe there is some pain previously and there is an increase in the symptoms, which suggests that there is a superadded urinary tract infection. There may be changes in the characteristics of the urine, like the urine can become cloudy or turbid, as we call it. The urine may have a very foul smell associated with it, or sometimes there may be blood associated with the urine. All these are specific symptoms. If somebody has these symptoms, they directly point towards an involvement of the urinary tract or the urinary system. But like I said, some patients may present with very non-specific symptoms. There may be generalized pain in the abdomen. There may be patients may complain of just back pain or maybe just constipation. There may be, loss of appetite, that is anorexia. There may be changes in the mental status of the patient. There may be a decline in the functional status. The patient was able to do some activity, but over the last some time that he's been unable to do that particular activities. There may be confusion, which is increasing in this group of patients. There may be a change in the way the patient is walking, and there may be an increased tendency to fall. All these are non-specific symptoms, but it has been shown that when we try to evaluate these symptoms, many patients have been found to have an underlying urinary tract infection. So all these, symptoms may be associated. There may be an associated increasing in the incontinence of the patient. Some people have some degree of incontinence, and that increases when there is a urinary tract infection. All these symptoms are indicative of an infection somewhere in the body. And as I've already told you, urinary tract infection is a pretty, high probability of having is a very pretty common infection in the elderly population. So when we evaluate these symptoms, where in many patients it has been found that they have an underlying urinary tract infection, which is presenting as these non-specific symptoms. So diagnosis becomes difficult at times. If we have specific symptoms, it may be easy to diagnose. But if there is a non-specific symptoms, then it becomes slightly difficult. In those cases, we have to go by our clinical judgment, and we use a combination of the specific and non-specific signs and symptoms. In addition, the clinical suspicion has to be confirmed by doing certain lab tests. The most important test is a urine examination where we look for the presence of WBCs in the urine. We also look for the presence of leukocyte esterase or nitrites in the urine, which give us some idea about the presence of a urinary infection. A urinary culture is also done not only to look at the organism which is causing the specific infection, but it also gives us an idea about the antibiotic sensitivities of those patients. So this is important to be able to plan treatment, as we will discuss in the next slide. An ultrasound to look for a post-void residual urine. That is, after passing urine, how much urine is retained in the bladder is very important, because the obstruction may be a reversible factor. It may be a correctable factor. If there is some obstruction and that obstruction has been taken care of by medical or surgical options available, we can prevent further infections of the urinary system and all the morbidity associated with it. Coming to treatment, now treatments, see, before that, we need to understand that the commonest organism that we usually encounter with urinary tract infections is E. coli. There can be other organisms, but the commonest organism still remains to be E. coli. So the antibiotics are usually chosen based on the experience of the doctor as to the local sensitivities of the organism. So that is known as an empiric antibiotic therapy. So this empiric antibiotic therapy is started immediately once the patient presents to you, and that antibiotics may have to be modified if the urine culture shows either a different organism or a different pattern of antibiotic sensitivity. In those cases, the antibiotics may need to be modified. How long to treat? Now, that's a very difficult question to answer. It depends on whether it is a complicated or an uncomplicated UTI. By the term complicated, we mean that whether there is any other factor which increases the risk of infection or which makes it a very difficult infection to treat. These factors can be presence of a urinary catheter. It can be presence of some sort of obstruction in the urinary system. It can be due to presence of stones, etc., in the urinary system, which make it difficult to treat these infections. And there is a higher chance of recurrence of infection in this group of patients. Whereas in uncomplicated UTI, the duration of antibiotic therapy is generally about 3 to 5 days, whereas in complicated infections, it can be a longer, up to 2 weeks to 3 weeks. In some patients, we need to give antibiotics for a longer period of time, which is known as chemoprophylaxis, especially in those patients where they are developing infections more frequently or repeatedly. In that group of patients, we follow a regime known as chemoprophylaxis, wherein an antibiotic is prescribed at a lower dose for a longer period of time. Coming to the most important part of my talk, which is prevention of urinary tract infection. We have all seen that urinary tract infection is more in the elderly, and it has its own set of problems. So it is better if we could prevent the infections in some way or the other. So many, pharmacologic and non-pharmacologic methods have been studied, as in many medicines and other non-medicinal way have been studied to try and prevent the urinary tract infection. It has been shown without any doubt that people who are able to walk have a lesser burden of urinary tract infection. And so it is very essential to maintain or improve the mobility of the patient with the help of exercises, physiotherapy, or whatever is required. The aim is to keep the patient mobile. If the patient is bedridden, there is an increasing chance of urinary infections. So, the more mobile the patient it is, the better it is with regards to urinary tract infection. Next is sufficient fluid intake. Now, many of these elderly people may be suffering from diseases like chronic kidney disease or heart diseases, where their fluid intake may be restricted by the treating doctor. In this group of patients also, we should try to achieve a fluid balance wherein at least sufficient amount of fluid is given and good urine output can be achieved. In the other population where there is no such restriction, sufficient fluid intake should be ensured so that the urine output is good and there is no stasis of urine. This has also been shown to reduce the incidence of urinary tract infections. It goes without saying that good genital and urinary hygiene is of prime importance in the prevention of urinary tract infection. Prevention of constipation has also been shown to reduce the incidence of urinary tract infections in the population. Now, coming to certain drugs, many drugs have been tried, but there is final word is still yet to be out as to what is the best therapy to prevent urinary tract infection. People have tried cranberry juice, which contains an active ingredient known as proanthocyanidin, and this has been shown to prevent the attachment of the E. coli bacteria to the epithelial cells of the bladder wall. But there has not been any definitive trial which can say for sure that use of cranberry juice will prevent urinary tract infections. Moreover, the other problem is that we need to take a very huge amount of the cranberry juice on a day-to-day basis to be able to show some result in prevention of urinary tract infection. In postmenopausal women, the use of intravaginal estrogen has been shown to to reduce the incidence of infections, but again this is of there is limited clinical evidence with the use of estrogen. Many other drugs have been tried like oral lactobacillus formulations, d-mannose, but the final word is yet to be out before we can make any definitive recommendations. Many more trials would be required to prove that the use of these medications definitely prevents the urine infection. Now, there is a special group of patients, those who require catheter, either short term or long term, who are prone to develop infections. This I have stressed in the initial slides. And this is the group where a lot of things can be done to help prevent the occurrence of infection or for early treatment of infection. The first and foremost is we should continuously reassess the need for the catheter. The moment the treating doctor feels that the catheter is no longer required, we should get rid of the catheter. Even before placing a catheter, we should try and explore other options as to whether we can avoid or delay putting in a catheter. But if it is unavoidable, we put in a catheter with all aseptic measures in place. Aseptic handling of the catheter is very important. Not only while the catheter is being inserted, at that time obviously the focus is high and so everybody is taking aseptic precautions, but aseptic precautions is required while handling the catheter on a day to day basis. One important thing which is important to understand here is the proper positioning of the catheter. The catheter and the urinary bag should always be positioned in such a way that there is no backflow of urine from the urinary bag into the bladder, because that can obviously increase the risk for infection and uh, cause problems for us. So proper positioning of the patient, wherein the urinary bag is always at a lower level as compared to the patient, whether the patient is sitting, standing, or lying down. It is very important to maintain that proper direction of flow of urine, so that there is never a black backflow of urine. And already I said that we should use the catheter for the minimum duration and we should remove it as soon as possible. Many people have tried using an antibiotic coated catheters. They can be silicone catheters or maybe nitrofurantoin coated catheters. Some People have definitely found good benefit with it, but the still the aim remains to remove the catheter as soon as is possible, practically possible. In people where we are unable to remove the catheter, and we understand that it will be required for a longer duration of time, then we can use an antibiotic coated catheter. The advantages being we need to change it less frequently, and because of the impregnation of the antibiotic in the catheter, we can prevent some infections with that. So to summarize my talk, urinary tract infection is a very significant and an important problem in the elderly population, especially in the elderly population, because the elderly population is much more vulnerable to the side effects of urinary tract infection. There can be increased morbidity and mortality. There is an increased cost associated with care for urinary tract infections. There is an increased risk of hospitalization with urinary tract infections. The problem is the presentation can be vague at times. There can be non-specific symptoms, especially in the elderly and those who cannot express their problems to us. Those who have dementia or those who have certain other cognitive deficits, it may be they may not be able to exactly express their problems to us, and it will lead not only in difficulty in diagnosing the patients, but also in difficulty in managing this group of patients. Previous UTI, it is also important to prevent UTI because previous UTI is one of the most important risk factors for the next UTI. So, as the time old adage goes, prevention is better than cure. With that, I would like to thank you all for a patient listening, and I would like to complete my talk.
So, thank you, Dr. Anupam. A lot of information and lots of learning points here. I would like to ask a few questions. So, a
Sure,
couple of
ma'am.
them are coming from audiences. So, one question is I feel the urge to urinate, but I really can't pass urine. Or sometimes a little urine comes out, but then I constantly feel like urinating now. I'm confused about which doctor to consult, a gynecologist or a urologist.
So, we don't know the age of the patient or neither that whether it's a female or a male. If
It's a
it is
female,
a
that's why I'm telling
female patient,
gynecologist.
yeah. Yeah, so obviously we should consult the gynecologist first, and then we should look for the presence of urinary tract infection. And like I have mentioned, whether there is any obstruction in the urinary flow, which is causing this problem of repeated urge to urinate and an inability to completely void the urine. So maybe a gynecologist would be the first point of contact, and we should rule out any obstruction in the urinary flow.
So डॉक्टर साहब a lot of okay, another question has come. सर मेरे पापा 17 years old हैं और उनको यूरिन इन्फेक्शन हो गया है. मैंने बहुत डॉक्टर्स को दिखा लिया है किंतु कुछ भी काम नहीं हुआ है. प्लीज सर कुछ सॉल्यूशन बताएं. 70
देखिए
years
पूरे
old papa seen for
यस
UTI by several people, no benefit.
नो बेनिफिट, हाँ। नहीं, देखिए ऐसे केस में हमें इवेलुएट करना पड़ेगा कि ये इन्फेक्शन बार बार क्यों हो रहा है। एक पॉसिबिलिटी है कि या तो कोई रास्ते यूरिन के रास्ते में रुकावट है, जैसे कि मैंने कहा प्रोस्टेट ग्लैंड बढ़ जाता है, तो उसमें यूरिन के रास्ते में रुकावट होती है। कई बार यूरिनरी ट्रैक्ट में स्टोन होता है, जो छोटा सा स्टोन होता है, या फिर प्रोस्टेटिक ग्लैंड में कई बार एब्सेस बन जाता है, कभी किडनी में पस की कलेक्शन हो जाती है। ये बहुत सारे कारण हैं जिनकी वजह से यूरिन इन्फेक्शन कई बार ट्रीट नहीं हो पाता है, डिस्पाइट गिविंग सो मेनी एंटीबायोटिक्स एंड कंटिन्यूइंग देम फॉर लॉन्ग। उस केस में कुछ और टेस्ट और कुछ और इन्वेस्टिगेशन जैसे कि सीटी स्कैन वगैरह करने के बाद ही हम डिसाइड कर सकते हैं कि ये यूरिन इन्फेक्शन बार बार हो क्यों रहा है। वंस वी नो ये बार बार क्यों हो रहा है, उसके बाद हम प्रिवेंशन या ट्रीटमेंट की तरफ आगे बढ़ सकते हैं। कारण पता होना बहुत जरूरी है कि इन्फेक्शन है क्यों।
My dad has sediments in urine about 2 months ago. When he got it tested, the result came back negative from my urologist. Should we seek a second opinion?
That will depend on why the sediment was there and what kind of a sediment was there. There can be many sediments. It can be, blood. It can be some crystals. Some people have crystals in their urine. So, what kind of sediment? That is one. Second, if it needs to be seen whether he has any symptoms as of now. If since it's already 2 months, and if there is no symptoms, and if the sediments are not persisting, then we can wait. But if he has some problems, as in, I have tried to outline the problems. There is any urgency, there is any frequency, or there is any pain while passing urine, or if there's any blood in urine, obviously we need to evaluate and then look at it again as to what is the issues concerning here, and only then we can provide a specific answer to this question.
Sir, in urine analysis, okay, another question. I need help. I am 21 years old. I went to the doctors 4 times and they gave me pills. They work for like a week or 2 days and pills are not helping. What's going on with me? This is a female patient,
Yeah.
21 years old female, telling
Yeah.
she's given pills. She took it for a week, then she took it again for 2 weeks, but not helping.
So it would be important to know if a urine test was done. A routine physical examination of the urine sometimes is a gold mine of information. We can get so much information out of that simple urine examination that maybe we can provide a better solution to the young lady, and she should be free from her symptoms. But I would suggest that a urine routine examination should be done, and then proceed before taking any antibiotics or any pills, just empirically, because she's already taken pills, as I understand, for 2 times. And if it's a frequent issue, say more than 3 times in 6 months, obviously we need to look at a routine examination at least, to decide how to proceed from here. So I would suggest a routine examination to be done, and then discussed with proper either physician or a gynecologist or maybe a nephrologist to decide how to proceed from here.
Sir, in urine analysis, test albumin is trace, sugar RBC is 5 to 6, leukocyte is 6 to 8, the rest are normal. Is it UTI? RBC is 5 to 6, leukocyte 6 to 8, and albumin trace. Nothing else
So,
is bothered.
we need to know if there are any symptoms or not. The age of the patient is also very important to be taken into consideration. But yes, presence of 5 to 6 RBCs, if it's a male patient, it is a very high RBC count. And WBC 6 to 8 are just borderline, neither here nor there. But if the patient is symptomatic, then we can, proceed further. Maybe we do a urine culture and see what kind of infection. We need to see whether there is any history of a urinary tract infection in the past, if the patient is on a catheter or not. All those issues need to be, looked into before we can just label it as a urinary tract infection. But yes, this urine report can suggest a urinary tract infection, especially if it's an elderly gentleman on maybe a catheter, or maybe who has, prostatic hypertrophy leading to retention of urine. It may be corroborative. Like I've already said in my talk, it is always a corroboration between the clinical symptoms and the laboratory findings. None of them can be individually taken to, make a diagnosis. We need to look at the complete picture before we can actually make a diagnosis. But yes, it does suggest that there are some problems which need to be tackled, especially the RBC count, which is high. 5 to 6 RBCs in a male patient would be high. We need to look into it.
How to know if dementia patients have UTI? Because as you said that they can't describe their symptoms.
Yeah. So, madam, in this group of patients, it is more like we have to be on the lookout for the presence of a urinary infection. Any change in the clinical status of the patient, or maybe in the sensorium of the patient. Suppose the patient has been normally being able to go for a walk, or normally being able to go to the washroom on his own, but nowadays is not able to go to the washroom. He's unwilling to get out of bed. The appetite for food has decreased, or there is nausea, vomiting. Sometimes, low grade fever also these patients can develop. So these would be the symptoms that would prompt us to look for a urine infection. And then obviously we need to look at a urine routine and maybe a culture to confirm our diagnosis. But these subtle signs should not be ignored, because many a times we have seen that there are subtle signs non related to the urinary tract, and then we realize that we have been missing a urine infection for quite some time,
So how
especially in
often
patients
do
who
you
cannot.
think
Sorry,
how
ma'am.
often do you think an elderly should be doing a urine routine every couple of months or year if they have no symptoms?
Madam, if there is no symptoms, there is no need to do a urine. No, symptoms as in specific and non-specific. Let us be very clear with that, that the patients may not have a specific symptom to the urinary tract. Some people, elderly people with dementia or maybe some other diseases, they can have some degree of incontinence to which they have got used to, some degree of frequency or urgency to which they have got used to. But if there is any change in these symptoms, if the frequency, say it was initially every 1.5 hours. Now the patient is passing every 30 minutes urine. Patient is saying that I am unable to pass the urine. The moment I get back from the washroom, I have an urge to go again. And the moment I have an urge, I cannot hold it any longer. So any worsening of these symptoms may be there to a lower degree. But if there is any worsening of these symptoms, we need to be careful. As such, there is no recommendation to do a urinary tract infection, say monthly or quarterly. But if there is any symptom, then we have to be proactive and get at least a urine examination is one of the simplest examinations. And take my word, madam, it is one of the most neglected examinations. Nobody wants to do a routine urine examination. We come across patients who have a whole battery of tests done, but they don't have a simple urine routine examination with themselves. So that makes things. So that is why we, as a nephrologist, I keep on stressing the need for a urine examination. So that is where it is. There's no recommendation to do it as a fixed period, but yes, whenever there is a doubt, in consultation with the physician, we should do a urine examination.
So elderlies they feel a little ashamed in mentioning UTI. So how to manage that?
Yeah, it can be a stigma at times. Yes, I completely agree with you. Some people do not want to, include the word UTI or that matter. But again, let me assure everyone that patient confidentiality is a very important aspect in anything that we do. From a physician's perspective, this aspect is never discussed with anybody unless it has the explicit, consent from the family and the patient. And but if there is a problem, we cannot just hide behind the problem and ignore it, because a urinary tract infection, it may be initially just in the bladder, but then it will take no time to spread into the kidneys. At that time it becomes a real mess, a very big problem to treat and manage pyelonephritis. Not only does that lead to hospitalization, it leads to antibiotic courses for longer periods of time, costlier antibiotics, stay in hospital, and all those things become very difficult. So we cannot hide behind a symptom or a problem. Any problem there has to be tackled professionally and with somebody with enough experience to handle something. Rest, confidentiality is assured. There is no question of any, leak of confidentiality or anything with these kind of issues. Or for that matter, any treatment, it is confidential between it's a between the doctor
Doc-
and the patient.
So the next question is just going through UTI infection and now slowly coming back with more focus. Taking antibiotics for a few days, but still not fully as sharp as I was. Will I return to normal? I am 64 years old. This is a 64 years old lady. She's taking treatment for severe UTI. She's recovering, but she's feeling very low on energy, looks like, and she's not feeling mentally very sharp and agile. So she wants to feel whether I will return to normalcy.
Yeah, I think we should return back to normal because age is not very much. It's just 64 years of age. But she's not mentioned whether she has any other comorbidities like diabetes or maybe a chronic kidney disease or something. If everything else is normal, we expect that she should get back to her normal, and she should do well for this thing. But the thing that I would like to say to her is that she should be careful for future events of UTI. I have already mentioned that one UTI will predispose to another UTI. So a complete assessment at this point in time and for prevention for the future would be the best way for her so that she doesn't suffer again. That is what our consideration should be at this point in time. But I have no doubt that she would return back to normal and should be able to do all her activities and all her, whether she goes for yoga or for a walk or for, any activity that she is interested in, she should be able to do her activities. Should not be a problem at all.
I'm suffering from UTI from a very long time. I use some medicine to stop it for some time. I get clear, but after some time it comes back and causes pain in my lower back. Please answer. So this is a male, but the age is not mentioned.
Yeah. So obviously this is a recurrent UTI. I don't know if it how frequently he is getting. Is it getting a monthly basis or is getting on a 6 monthly basis? But definitely there is a recurrence of the urinary tract infection. If it's a male, elderly male, I would assume there may be some obstruction in the urinary tract. There may be some issues with the prostate which need to be, looked into and tackled. That if we can tackle that in prostate issue, if it is a prostate issue, then maybe we can prevent the further episodes of urinary tract. Second is if there is no prostate and if it's a young male, we would assume then he should increase his water intake. Maybe he is office goer, not able to drink enough water, or maybe he has a job where he's not able to drink enough water. In that case, sometimes can predispose to recurrent infections. So increasing the water intake will definitely help. Water intake increasing means about 2.5 to 3 liters of fluids a day, at least in this warm zone that we stay in. Maybe more, but at least 2.5 to 3 liters of water in a day. Secondly, if there is a recurrent urine infection, we can look into providing chemoprophylaxis. Like I mentioned, we can give a short, low dose antibiotic for a longer period of time and hope that the infection is doesn't recur. Third is the gentleman can also try maybe cranberry juice. We don't know, but yes, it has helped some people. Some people may be able to tolerate it, and some people may definitely get some benefit out of cranberry juice, which can be tried. Definitely can be tried.
Any modification to toilet design to avoid urinary infection?
Sir, if we are using a Western toilet, it is better to clean the seat before, and especially if it's a public toilet. If it's a personal toilet, I assume hygiene would not be a concern. But hygienic concerns come up more in the public toilets. As such, I am not aware of any modification which has been recommended to avoid UTI. But yes, clean toilet seat would be very important to avoid a urinary tract infection. More so for female patients. Yeah.
So, hello, sir. Too much foam formation is there in my urine, but no smell or pain.
Pain.
Is this a problem?
See, foaming or frothing of urine can sometimes be a marker of, protein in the urine. High degree of protein in the urine can some present as frothing of urine. So, what I would recommend is if there is no other problem, just get a urine routine examination done. If that's okay, then maybe we can still, wait. Otherwise, you can consult a physician. But a urine routine examination, a simple urine routine examination, any time in the day, a midstream urine should be good enough to tell us based on your symptoms whether there is any protein in the urine or not. That would be the only concern in.
So, there is another question. Like, what happens, as you said, doctor, that anybody who comes with a symptom, they should first do a urine routine and, if required, a culture, and then we give antibiotic according to the culture report. Now, what
Yes, ma'am.
happens after culture? It is not clear whether the infection has gone or not. So, what is the recommendation for a repeat culture to prove that it is clear after how many days?
Madam, so there is no recommendation as such to repeat a culture. It is what we generally do is if it is a first infection, then based on symptoms, we can maybe repeat a urine routine after some days and see that there is no pus cells or anything. and we can also corroborate with the improvement in symptoms, the clinical condition of the patient. But if it is a patient who has had a recurrent urinary tract infection or somebody who has pyelonephritis, in that group of patients, we can look at other markers like maybe a TLC or a CRP, ESR to look at the presence of infection. And obviously, if the infection is persisting or if the symptoms are persisting, maybe we can repeat a culture. Actually, repeating a culture sometimes can be fallacious also, because if somebody has taken antibiotics, there may be a false negative urine culture as well. So, like I always say, I'm sure you would also agree that it is a combination of the clinical symptoms and the laboratory corroboration with the laboratory findings which help us in deciding whether how to proceed, rather than
So,
making any blind blanket statement.
but doctor, so
Yes,
many
ma'am.
times when we send urine routine and culture, the reports don't match. When you see urine routines suggest a lot of infection, there is nitrite or estrase positive, and then there are pus
Yes,
cells,
ma'am.
and
Yes.
the culture comes negative. And on the
So, ma'am,
other
there.
hand, yeah, please
Sorry.
first this half, yeah.
So, ma'am, it can be both ways. I think you are trying to say the same thing, that there is not much pus cells, but the urine culture comes out positive. So, it depends a lot on how the urine sample has been collected for the this thing, and obviously in relation to what antibiotics or what other treatment the patient is taking. So the suggestion is always to collect a midstream urine sample before we can actually say that the urine culture. Sometimes the urine culture will show three or four or multiple organisms. That also makes us confused. Moreover, we also need to look at the colony count of the organism which is growing. So a significant colony count is more than 10 to the power of 5. Somebody who has 10 to the power of 2 or maybe 10 to the power of 3 with no symptoms, again it becomes difficult to this thing. But in that group of patients, we need to see if the patient is catheterized or has a stone or an obstruction. In those cases, it may still be significant, but generally for understanding, it is more than 10 to the power of 5 colony forming units that we take as significant. That is one. Second is obviously the clinical symptoms that we keep in mind. And the most important thing is, I keep on stressing, is a proper collection of a urine sample. A midstream urine sample after proper cleaning of the vagina, local parts, genital parts, and then collection of the urine sample is what ultimately will help us in making a correct diagnosis and giving a proper cure and relief to the patient.
So, Dr. Saab, there's a lot of myth that only first morning sample should be given for urine testing. Is it right?
Ma'am, yes, this myth is there, but for a urine infection, it can be any sample in the day. Only thing, it has to be collected properly. First morning sample, rather the second morning sample is what we want to look for presence of RBCs or maybe protein in the urine. But for a
Yes.
urine infection, any time in the day, but the collection of urine has to be proper to achieve correct results and good outcomes with the patient.
And sometimes what happens is urine routine is absolutely fine and the culture shows significant colony count like more than 10 to the power 5. Then why there are no pus cells in the urine? So what's the explanation? Again, poor collection?
Ma'am, yes, there can sometimes be contamination during the collection, where suppose the container is not clean in which it has been collected, or there is some other, there are n number of reasons which can lead to a symptom like this. Generally, if there is urine infection, we should have correlation with a urine routine examination, as in presence of leukocyte estrase, nitrites, or pus cells, or maybe RBCs in the urine. Sometimes what happens is the urine is collected from the urine bag rather than directly from. In a catheterized patient, it can be difficult at times. We cannot take a fresh sample in those patients. We collect it from it's collected from the bag because it's easy to collect from the bag. But that defeats the whole purpose of doing the urine culture thing. So those are things that we need to look on an individual basis. Individual patient has to be understood, and then maybe take a call, which I'm sure you are doing. But that's how we
So
proceed.
yes, yeah. So there, if there are significant symptoms, we will do urine routine, urine culture, and post-void residual urine by ultrasound at the same time, right? But if there are mild symptoms, we just first do urine routine and see, and then decide whether the patient needs
Yes,
culture
ma'am.
and
Yes, ma'am.
ultrasound.
Uh,
Meanwhile, we
exactly.
request the patient to monitor the symptoms, input, output, see how much water they're drinking, what's the frequency,
Yes.
and
Yes.
actually that they are habitual passers. Sometimes we realize that they have no issues, they're just habitual passers. And when we do the
Yes, ma'am.
bladder retraining, this is just after pregnancy, probably little more applicable to elderly women, that they get
Yes,
used to
ma'am.
passing urine every now and then for fear of leakage because of the
Yes, ma'am.
urinary incontinence, which is stress essentially. And then if we start retraining, they fare better. So thank you so much, Dr. Anupam. It was a pleasure
Thank you,
speaking to
ma'am.
you. Thanks for your time. Thank you, audience. Thank you. Sorry we got delayed this time. Next time we'll be more careful. Thank you.
Yes.
Thank you. Good day. Thanks.